Welcome to Care Chats. Join palliative care experts sharing stories, information, and strategies. We're passionate. Join us, and let's get comfortable with palliative care.
Welcome back to Care Chats. I'm Brooklyn, a palliative clinical nurse educator at the Grey Nuns Community Hospital, and I'm joined today again with my lovely co-hosts, Danica, a palliative education lead with the Palliative Institute, and Jen, palliative nurse consultant at the University of Alberta Hospital. All three of us trained on a tertiary palliative care unit. Before we get started, I would like to encourage you, the listener, to take a moment at the end of this episode to fill out our feedback survey linked in the description below. We will also be hosting a future mailbag episode, so if you have any burning questions about palliative care, feel free to include in your feedback or comment down below. Today is an exciting episode as we have our first guest speaker joining us today. Christine Enfield is a chaplain at the Grey Nuns Hospital who has worked on the tertiary palliative care unit for 13 years. And all of us have had the pleasure of working alongside her and the amazing care she provides to our patients. Welcome, Christine.
Hey, everybody. Good to join the chat with you today.
Thanks so much for joining. So last episode, we talked about caring for the patient at end of life, and this week we'll be focusing on how we can care for the family. Caring for families of imminently dying patients often involves providing emotional support, practical assistance, and clear communication, while also acknowledging their unique needs and coping mechanisms. Healthcare providers should strive to create a supportive environment where families feel informed, involved, and empowered during this difficult time. So, how do we actually do this, ladies?
Yeah, that was a lot of buzzwords, Brooklyn, but I love the description of all the things that are included in caring for the family. And I think one of the first things we could focus on is establishing a supportive relationship. So, what does that mean? It means building trust and rapport with the patient and also the family. So, whoever is hanging out at their bedside. And how do you do that? I think one of the most important things in communication, we'll bring this up a lot in this episode, is active listening. So making sure we're actually understanding what their concerns are, we're validating their feelings, and we're offering reassurance. And it can be as simple as taking a moment to listen. Whatever they say, you're just repeating. I hear that you're really sad. This must be hard. And then you just pause and see what happens. Often just taking a minute to acknowledge their feelings, repeat what they're saying, it will open up a huge door for them and for you. Another practical thing you could do is consider a comfort cart or comfort packages on your unit. So think of a few things that you can put together to offer for families that are staying. Do you have instant coffee that you could set aside or non-perishable snacks? Maybe you have puzzles or books. You could also check with your site volunteers. Sometimes they have resources and ideas that can supplement a comfort cart. One site that I worked at, they had volunteers make heart blankets and they were placed on the patients when they were dying. And then after they died, the family could take them and it was sort of a keepsake of that moment. So I thought that was really nice.
Love that you also mentioned puzzles and books. These can also not just be for adults, but to tailor them for children if they're coming to visit their parent or grandparent. Having books available that are age appropriate for the children that talk about death can be a great resource to have available. Lots of parents may struggle with how to explain to the children what is happening to their parent or grandparent.
I was just going to interject there because there's something we just started using on our unit. They're called connecting hearts. So I have a volunteer that makes these two kind of crocheted, almost identical hearts. And there's a little piece of paper that I put in with the bag of the hearts. And the intention there is it's like a symbol of enduring connection and love between the patient and their loved one. So the hearts can be one stays with the patient, the other one goes with the loved one. So they could exchange those while the patient is still alive, or it could be something used in bereavement at the time of death. So I'm just starting to use them. I found that there's been quite a good response to them. Use them with kids, but adults as well seem to like them. So that's another idea.
I love that idea.
Very sweet.
I'm so excited to see it in action.
Hmm. It goes really well with a book that we use on the unit that we give to families often. It's called The Invisible String. So some of you may have heard of that book.
Is that to teach children about end of life?
It's not actually. It's between two kids and their mom talking about how they feel when they're not physically present with their mom, if there's a storm or they feel scared or anxious. And then she tells them about this invisible string between their hearts. And if they feel alone or they miss her, to just kind of pull on the string and it will remind them of their connection no matter where they are. And so that can fit in with a bereavement idea as well. So we use that book quite a bit.
I'll add it to the list of resources that you can find at the bottom of the episode.
I will also just add that specifically with talking to kids about serious illness and grief, I find the Children and Youth Grief Network really helpful for resources as a website. Like they have a really nice top 10 things that you could do to talk to them,
Mhm.
which is really helpful. I'm also lucky enough to work in a hospital where we have access to child life for advice or their expertise when it comes to patients who have small children.
That's a great little conversation about children and how we can also include them and care for them when we're caring for families. Another thing that is obviously one of the most vital things when we're talking about caring for families is providing clear and honest communication and facilitating open discussion. Communication is such an essential part of palliative care, as Ira Byock, an American physician and advocate for palliative care, so eloquently puts. Communication is not ancillary or a chore in palliative care. Rather, it is the core therapeutic medium of our discipline. The time it takes palliative clinicians to effectively listen, convey information, and respond to questions and concern is not time taken from our medical practice, it is the practice. So, communication is really at the heart of what we do, and making sure that we're also communicating in a way that is simple, using everyday language to explain the patient's condition, prognosis, and anticipated changes. So, this isn't just for children, also, adults need to have things described in a way that they can understand. So, it is especially important when there is a language barrier. So other families can be used as an informal interpreter, but this could also cause additional stress to the family, or they may not be able to clearly interpret what's being said. And so using a formal interpreter may be useful depending on the circumstances and the conversation being had. Another really important part about communication is encouraging families to ask questions and express their fears and anxieties, creating a space where they feel comfortable sharing their thoughts and their feelings without judgment.
Another thing I want to stress here is remember that you will have to repeat information, and that's okay. The people that you're talking to are going through an extremely stressful experience, and it's not that they're not listening to you, and they're definitely not trying to be difficult, but they may actually just forget. They may be exhausted. They are very likely emotional. So making sure that you're keeping the information simple and short, as Brooklyn already said, and consider answering questions throughout your shift instead of having one big conversation, which can sometimes be overwhelming. And then also pairing your conversations with tangible information. So whether that's sharing links and you can, if they give you their device, you can just like go to the web page on their cell phone and like it for them or save it for them, or you can print pages off of websites or give physical pamphlets if you have some on your unit. This is really helpful to just reinforce your message. And then another key thing is to make sure that the whole team is sharing the same information. So connect with the oncoming shift and the outgoing shift and let them know what you've talked about on your shift so that they can reinforce your message instead of accidentally contradicting it.
Those are some really good points, Danica. Some other great ways to develop rapport or build relationships with the family is to introduce yourself to any new visitor that's in the room. Ask them their name and how they know the patient or what's their relationship to the patient. You don't want to accidentally mistake the relationship, as I have done in the past before. So always good just to ask. And then once you kind of know who those family members are, The ones that are really important is to make note in their charts so that other staff know as well. And then they kind of become part of the person that you're caring for. Additionally, in my own practice, I make a pointed effort anytime I'm in the patient's room to do something for the patient, whether it's just to give meds, reposition, do mouth care, is to check in with the visitor or the family that's present, allowing that space for families to ask questions or express how they're feeling. It can be simple as asking them, "How are you doing? Do you have any questions or concerns? Does your mom, dad, spouse, wherever that patient is, seem comfortable to you?" This helps to get their perspective and include them in the care as well. Another really important piece of communication, especially at end of life, is educating the families on the anticipated changes they may see. Normalize the signs and symptoms of someone that's imminently dying as well. So over the years, I feel like we've all developed our own little script of what we use to families. So, ladies, if you were to describe the anticipated change to a family member that they may see as their loved one approaches death, what are some of the scripts that you use?
What I would say would tie in a lot with what you would say, except that I'm not medical staff. So my input would be very simple as I am asked. So I think that's important sometimes to consider too, is that people will receive the information when they're ready to receive it. So if someone did ask me, I would probably point out a few of those things that you would undoubtedly say about not drinking or eating as much, sleeping more, changes in the urinary output, changes in breathing and the circulation and things like that. But I wouldn't get into a lot of details. What I do try to do is kind of join the space with them. And so after being with them a little bit, I might ask them, how do you see your loved one today? Like, what are you noticing today about how they're doing? And then let them tell me what they're thinking, and it might leave some room for some concerns. And then I can act as a bridge to say, if you're noticing things, if you're noticing that they're restless or their brows furrowed or changes in their breathing, or it seems like they're getting gurgly or congested, don't hesitate to ring the nurse and have them come and assess. You don't have to figure it out yourself. You can just ask them to come in and have a look with you and see if there's something they can do to make your loved one more comfortable. So I just kind of bridge that between the nurses and myself.
I like to use signs of death as an indication for prognosis. For example, I'm noticing breaks in their breathing, which we can expect to get longer and longer. Those are called apneic episodes that can last up to even 1 or 2 minutes before another little breath is taken. So just describing Cheyne-Stokes. And when this happens, I expect death to occur within minutes to hours. And I use language like that because it tends to be very clear and descriptive with no room for interpretation. Like if someone's, you know, just breathing a little bit shallowly for a couple of minutes, then the family's not freaking out that they're imminently dying, for example.
In our last episode, we did talk about the different signs of death. So if you're more interested in that, feel free to listen to our previous episode. One thing that I also try to do is, especially, I find these conversations happen when patients' goals of care are changed. They often are like, what's going to happen? So that's a great time to bring forward what the potential signs and symptoms that they might see are. And I always like to say everyone comes into this world in their own way, and everyone also leaves this world in their own way as well. And so these are some of the things that we are looking for. Of course, if you have any questions or concerns, feel free to give us a call and we will come and assess the patient, just as Christine kind of said, right? Like, and we'll kind of assess to make sure that they're comfortable. The best way to learn how to kind of have these conversations and how to talk to families about end of life signs is to actually go and observe and listen if you have the opportunity to. Even after years of building our own scripts, it's interesting to listen to how others answer and respond. So there's a lot that we can learn from our fellow coworkers. But even when we provide education about what some of the anticipated or expected changes are, there are some common questions or challenging questions that are often asked. So we're going to go through some of these common questions that we do hear often and how can we answer them. So one of the first ones that we often hear is, should I stay or should I go? Danica, would you like to tell us how you would answer this?
Yes. So this question, it can be a tricky one because it can feel like that person is putting a lot of responsibility on you. So I tend to ask people how they feel. So they know themselves best. They know what kind of person they are and how they react to stressful situations or how they view regret or decision making. So I ask them, imagine yourself in 6 months or in a year and think back to the death of this person. If you missed it, how do you think you would feel? If they leave and they miss the death and they think that they would be okay with that, maybe they're okay with the amount of time that they spent at the bedside up to now. Maybe they've said everything that they wanted to say. Maybe they've had a really beautiful final conversation and they're okay with all of that. Then I tell them that's great for you. If that's how you feel, then you should go. And if they say, no, no, if I'm not here when it happens, I will be devastated, then I would tell them to stay. So it's really a very personal decision. And I also emphasize, and we say this a lot in palliative care, that we can't exactly pinpoint when someone will die. As Brooklyn said, you leave how you want to. And even if you have, all of the standard expected changes of end of life, you might be in that space for days, sometimes even weeks, unfortunately. And other people are in that space for like an hour or 2 hours. So it is really hard to say. And so I also try to take a little bit of the burden off by saying that, like, you really can't tell. You can do what's good for you, but it might not lead to the ending that you imagine.
Yeah, I do something similar. I kind of like to put the perceived responsibility in terms of being present at the time of death on the patient themselves. So similarly, patients will kind of choose that moment that's right for them. So, I've seen people actively dying for days, even weeks, and then they'll wait until right after a specific family member arrives at their bedside. I had someone wait for 3 weeks for their dog to arrive, right? I've also seen patients wait until their room is empty so we could have a family member holding vigil for days and they get up to go to the bathroom and that's when the moment of death occurs. So I like to frame it as any like last kind of vestige of control that the patient might have, and they'll choose their moment that's right for them. That way that family member doesn't have to feel guilty if they don't make it in time or guilty that they had, a bathroom need. I also get asked similarly if, such and such family member should come in from out of town to visit. And a lot of people will be worried that they're calling in family too soon before death. But I have yet to see a loved one be upset that they've come in to visit in the event of a false alarm. Like in my experience, nobody's really regretted that extra visit.
That's so true. And those are some great points. I think it's really important when we're answering this question with families is to honestly give the families permission to do whatever they feel is best and what they need to do. Because I think there can be a lot of guilt or pressure that they need to kind of stay there and maybe they can't. I mean, people do have other responsibilities outside of this journey that they're on. And so sometimes they're not able to maybe stay at bedside. And so kind of helping them work through what, again, Danica said is going to, in, 6 months, a year, 5 years from now, what's going to kind of best suit them and their journey and how they respond to grief. Another question that we often get asked is how long do I or how long do they have left? So, how do we answer this tricky question?
Well, as we've said already a couple of times, it's extremely hard to predict how long someone actually has to live. So I always start by saying that. And in fact, I was reading some research recently that shows that healthcare providers in general, this applied to a bunch of different disciplines, have a tendency to overestimate how long people live for. So I don't know if it's like eternal optimism or we're just, we're all hoping that that a miracle will happen, but we tend to overestimate. So when someone asks me how much time is left, I do a few things. I check the progress notes or I talk to the MRHP to see if they've given any kind of timeline and to make sure that whatever I'm saying is consistent with the rest of the team. I also use data from my own assessments. and base that on the signs of end of life that we discussed in the last episode to make an educated guess. I also use vague timelines like weeks to months, days to weeks, or hours to days, or like Jen said earlier, even minutes to hours. This gives people a time frame that they can work with, but it's not so specific. So it kind of alleviates some of the pressure from the healthcare provider as well.
And there's also always that caveat that people use to like, okay, well, based on the signs that we're seeing, we're thinking hours to days or days to weeks, but things can change acutely and we never really know. For MRPs, there's a really great resource through the Victoria Hospice Society called 10 Steps to Better Prognostication. And we have the link there in the resources. And it goes through what information to gather, like lab tests, function, disease burden, the surprise question. So, would you be surprised if this patient was still alive in a year, a month, a day? It gives information on how to communicate with families about prognosis. I've seen healthcare providers also frame prognosis in the context of the trend of deterioration. So I use this a lot at the bedside. So, have there been signs of deterioration in the last few weeks, in the last few days, in the last few hours? And it is helpful to get the families involved and ask them what they've noticed, because then oftentimes they'll kind of develop their own sense of how long the patient has left. So many families will tell me they've already noticed significant changes every day. Like the patient was having full conversations yesterday, today is only able to use one word answers. And that gives me a chance to kind of frame things in terms of prognosis.
That's a really good tip, Jen. Getting the families to tell you what changes they're noticing as a jumping off point to have conversations around other anticipated changes they may see in coming weeks, days, or even hours. So that's a really good tip. And I think you kind of alluded to that, Christine, yourself.
I think that's so important, is to ask the family, the patient, what are you noticing? What are you observing about what's going on with you or your loved one? I think it's a great opening. And then to pause, give enough time for people to really think about the question.
Count for like 5 to 8 seconds in your head quietly before you respond. Another very common question that we hear is, are they starving or are they thirsty?
When I get this question, I often refer to a great pamphlet that's available on the AHS BOLC website called Understanding Eating for Comfort. It has really good talking points about the natural changes that we expect at end of life, like decreased appetite. There might be pain related to eating and swallowing at end of life, how the progressive illness is causing the changes, and it's not an indication of the patient giving up or letting themselves starve. We also get those kinds of comments a lot, and that can be really difficult for families to wrap their heads around. Eating at end of life is a super emotional topic. Eating is often social. It represents life. It represents celebration for many people and in many cultures. So, keeping in mind that you might have this particular conversation multiple times because it's such a big part of people's relationships. And another thing to consider is giving people examples of ways that they can connect that doesn't revolve around food, because that's often a really common thing. People come to visit, they bring food, or they come around mealtime, or they'll bring a coffee or their favorite donut from Tim Hortons. And if that's not a way that they can connect with, that can be really emotional and distressing. So I will recommend, like, is there a game that you like to play? Like in my family, we played a lot of crib. And so crib is an easy game to bring to the hospital. You can just even hold your cards and you're kind of just like thinking about crib, or it's giving you connection without talking about food. Reading or watching something together, listening to music or putting on your favorite artist. If it's possible, going for a walk or going outside. These are examples of things that you could do instead of eating together or snacking together.
I think that's an excellent point, Danica. This is often a challenge with people that maybe come from a different culture than what I am used to. The feeding and giving water to the patient is so important, even like right up to the end. So The communication about what you said about eating for comfort, but also taking the cues from the patient might be messaging that has to be gently and consistently presented, but it can be challenging. I think you've all probably experienced cases like that.
Yeah, I like what you said about taking cues from the patient, and that's something that My Health website also recommends. Is the patient expressing interest in food, or are they thirsty? And that's really what patient-centered care is all about. It's
Mhm.
what the patient's interested in, not what the family thinks should be done.
Yes, that's a very tricky question to answer. And so those are some really good tips on how we can still provide connection when we are caring for families, and how families can provide connection with that patient, even if the patient is unable to eat anymore. Another question we get often is, are they drowning? This is especially common when we start to see more of that congestion or more of the secretions as the patient becomes more imminently dying. So, how do we answer this one?
Yeah, this is super common, and it is one of the, I would say, maybe more obvious signs of end of life because it's so noticeable. The easiest way I find to explain it to families is to compare it to snoring. So it may sound distressing to the people around or the people in the room, but the person experiencing it isn't feeling any pain or distress. So you might consider also talking about some other signs that they can look for that might indicate distress or pain. So we've already mentioned it, but looking for a furrowed brow or looking for clenched fists, or if the person is being restless, then those would all be signs that the person is uncomfortable, and then we can definitely intervene. But if they are relaxed, if their face is really soft, if they their hands are sort of open and towards the sky, then they're probably okay and they're probably feeling just fine, even though they sound kind of horrible. As Brooklyn also mentioned last time, oxygen suctioning is not always helpful in this situation. So interventions should really be based on the patient's specific experience, and that can be explained to the families as well.
That's a great way to kind of answer that question as well. It comes up very often. And so these are just a few examples of some of the common questions that families usually have at end of life. But if there's any, as you're listening, that you would like us to answer, you can always leave in the comments or on the feedback. And in our mailbag episode, we would be happy to answer some of your questions that you've maybe come across and you're unsure on how to answer those questions.
I would be really interested to hear people's feedback on what they say to families and what their
Mm.
experiences have been.
Mhm.
Yes, for sure. Because we, again, can always learn from what other people say. It's always fun when you're like, ooh, I'm going to use that next time. There are some other things that we also want to do when we're considering caring for families. And one of the things that we can do is involving the families in the care. So, whenever possible, we try and involve them in the patient's care, allowing them to participate in bedside support, providing comfort measures, and making informed decisions. Some family members find a lot of value in being able to provide care to their family member, but do keep in mind that sometimes family members have filled that caregiver role for a while and can be at risk for burnout. So, giving them permission to allow nursing staff to take over the physical care of the patient can allow them to focus on quality time with their family member and step away from that caregiver role and just become a family member again. One of my favorite ways to kind of facilitate this is after providing care or a bed bath to a patient, is I offer to move the patient to one side of the bed so that the spouse or even sometimes child can crawl in beside the patient and lay beside them. This allows them to have that meaningful connection that, again, they may not have been able to have in a while just because of the burden of caregiving or if the patient's situation didn't allow that. So that's one that I think family members have found very valuable to try and include if it's possible.
It's very sweet, Brooklyn.
Mhm.
Yeah, is there anything else that you guys can think of when you're trying to involve family in care?
When you were talking about that last example, Brooklyn, it made me think of at the end of a nice bed bath and patient's all cleaned up, that sometimes you'd put some lotion on the patient and maybe the family member would like to to gently massage that lotion into their skin for comfort.
That's a really good tip, especially if the family is willing to even bring in maybe the patient's own body wash or lotion that they use because it's that scent. The smell can really invoke a lot of memory. And so I think that that can be a really nice touch to add when we're caring for families.
I'm going to interject another example actually that was not so good. I had a wife of a patient tell me after the patient had died that she'd come in like a couple of days before he died, and some kind of scented product had been used for the patient that was not a scent she was familiar with, and it was very strong
Mm.
to the fact that she had to like wipe her mouth after she kissed his forehead. And I felt so bad about that. So it is sensitive, what we put on the patient. And I think that's really good to get the cue from the family or the patient what they actually like, or if they want no scent at all, because that is something that will probably stay with that wife now for a long time.
That's very true. That's a really good point, is to make sure that we're asking permission from the family first about if that's acceptable either way, right?
From a organizational standpoint, it would be truly be best if any like scented products or special products came from the family, but also from like an infection control OH&S standpoint. This is our hospitals and facilities are technically scent free, so we say all of this with a little bit of a grain of salt. And of course, if the patient were at home, then it makes the most sense that they would have their own products around.
Mm-hmm.
That's great. That's actually a good transition into our next point is when we're offering practical support. So this is often providing practical assistance with tasks such as arranging respite care, organizing paperwork, or connecting families with community resources. And this might be especially important in the context of a home death. And Jen, could you speak a little bit more about that and what
Y-
we maybe need?
Yeah, the caveat being that I am not the home death expert. I do not have experience in the community, but from experience in terms of supporting discharges for planned home deaths in collaboration with our esteemed colleagues with home care. These are some practical things that might be considered to have prepared for patients who are going home. So the first thing would be really important would be a green sleeve with their goals of care. Most people kind of put it on top of the fridge or kind of put in a magnet on the fridge so that if anything happens, all the caregivers kind of know what the goal is. And if it's a home death, I would hope that the goal of care would be C1 or C2. Similarly, planned home deaths usually involve an expected death in home form. The family doesn't have to fill this out, but usually home care is really good about helping them fill that out with phone numbers of who to call, specifically not 911, in the event of the death. So that's always good to have, usually with the green sleeve as well. List of important phone numbers for the family doctor, for medications, or if the patient has died, numbers for the pharmacy, for home care, all of the discharge medications to be arranged. That's really practical for a home death. I personally, from my standpoint in acute care, if the patient is still taking pills, if possible, sometimes it's just really nice to have the discharging team provide a prescription, at least for a small supply of injectable medications, in case this patient acutely loses the ability to swallow pills so that the family is not scrambling for a prescription in a pharmacy, after hours. And home care, in my experience, has been really supportive of that idea. Hospital beds, bed sheets. People don't often think about this because it's all provided in hospital, but yeah, like even just having, a fitted sheet for a twin bed and a soaker pad. Sometimes home care can help with the soaker pads as well. And incontinent briefs, sometimes through home care. Sometimes they'll have to buy them themselves. Depends on the situation, I think. But anybody who works in the community, please feel free to correct me in the comments. Clothes and towels for washing up, a basin to fill with water for the bed bath, right? How about a container to empty a catheter, for example, or something that the patient can, urinate into, like a urinal? Mouth swabs, we like to have those in hospital and they're not always available at home. Not everybody can use a toothbrush, so maybe even just having those foam mouth swabs at home is really helpful for mouth care, particularly in the very last stages of life when the patient's not able to take in any water. And I know I've said this before in the last episode, but I really like the list of who to notify after death in the bereavement packages that we provide, as well as the list of community grief resources. Like it's just nice to have for the family.
Those are some very good tips and helpful hints if we are caring for somebody that is planning to pass away at home, or unexpected death at home. Another thing when we are caring for families at end of life is to also acknowledge individual needs. Recognize each family may have unique needs and coping mechanisms. So, offering individualized support based on their specific circumstances and preferences. And in order to do that, that often involves having conversations with them. So, recognize that the illness journey has an impact on the family members as well. So, acknowledge their efforts, the challenges, the responsibilities that come when a family member is dying. It's important that family members are able to prioritize their responsibilities, but also attend to their own needs. And if we can help them kind of balance both, they may feel less burdened.
One thing I always do is ask the family who's holding vigil at the bedside when they last ate or showered. If I can, I'll try to support them with doing so. You know, I work in a hospital, so in a bedbound patient's private room, sometimes it is easy for a family to use the shower in their room, depending on the policy. Or, you know, occasionally if the meal trays are still coming in for the patient and they look somewhat appealing, then we might ask the family if they want to make use of it instead of having it go straight to the garbage.
There can be challenges with some family members really letting themselves care for themselves. So I think what we can do is try to encourage and maybe create space where, you're doing something with the patient, and they're going to step out and have them use that time for themselves. So, but mostly we can encourage them to do it. It's sometimes hard for us to get someone to do something that's obvious to us. So requires some patience.
Great little tips. Another thing when we're caring for family members is addressing anticipatory grief. So, acknowledging that family members may be experiencing anticipatory grief, the emotional distress that arises when anticipating the loss of a loved one. So, providing resources and support to help with these feelings can be really helpful. Would you like to talk a little bit more about anticipatory grief and what it is, Danica?
Sure. Anticipatory grief it's a really big part of the dying experience, and it's not necessarily something that a lot of healthcare providers are actually aware of or often talk about. Anticipatory grief can be so many things and it can show up in a multitude of ways, but essentially it's grieving the losses that come with a person's impending death. So it's before they die, but you're thinking about all the things you're losing. So it can be the patient themselves that are experiencing anticipatory grief and they're grieving their family members, or it can be a child of a person who's dying, who's grieving the next big holiday where that parent or that person will not be there. Or it can be a family member of a person who's dying, who's grieving their relationship, that it will never go back to what it was. And maybe they've gone through multiple cycles of anticipatory grief as their relationship is changing throughout the illness trajectory. All of these thoughts and the feelings that go with them can show up well before the person actually dies. So it's not a when the person dies, then your grief starts kind of situation. It's definitely cyclical.
I think that's a really important point to make is talking about anticipatory grief and knowing what it is, because oftentimes we can maybe some people if they're unsure about what anticipatory grief is, they can think it's maybe premature or the family's not grieving appropriately, but anticipatory grief is actually a very healthy part of the grieving process. And so being able to support the family in that is very, very important and can be very helpful to them in their grieving journey.
I think it's important for us to recognize that grief happens in different ways and it's expressed in different ways, and it's all part of a long experience with someone who's slowly dying or has this kind of progressive illness. So we need to remember that, maybe even to name it for what it is when we're listening to the family. Say, you know what, missing that is part of grieving, and that's normal. that you would think about things like that and what it's going to be like after your loved one dies. That's normal that you would think about that.
So, talking about how anticipatory grief is normal and expected, and even a healthy way to cope with grief, should we also maybe talk about complicated grief and the impact that would have on grieving family members? So, Christine, please feel free to jump in at any point, but complicated grief is really just a prolonged grief disorder, right? Where that kind of normal and expected grieving process doesn't really happen. And so it leads to people just having lots of trouble in their daily life afterwards, just significantly impacts the grieved person's life.
Hmm.
Mhm.
Yeah, unfortunately, when the person dies, we often don't get that much opportunity then, or any opportunity to support the family after they're gone. So that's one thing that I think is difficult for us because we don't have a bereavement program per se. So we're doing our best to recommend resources in the community, provide maybe some information about the grieving process and healing. We can do that while they're here. But I think the other thing is, again, providing space that's safe for people to begin to express how they're feeling. Sometimes allowing some time for the loved one to come out of the room, maybe while the nursing care is being provided, and I'll take them to a private space just to say, let's maybe debrief a bit how things are going and how you're feeling. I want you to know there's a safe space here for you to cry, express yourself, say what you're scared of or what you're worried about. Maybe they just need someone to allow them the space to do that, and that might be helpful as they're allowing themselves to begin to feel. That's just something that comes at the top of my head. But yeah, I think I think that it's difficult when we can see the signs that somebody may be more at risk for that kind of complicated grief experience. So the best we can do is surround them with as many resources as possible, or the other family members around them to say, I want you to know about this in the event that your loved one might need some support, because we recognize there's a lot of complicated things that go into how we understand the loss. So I think that's the other thing. Like there's a lot of complicated things that go with that. Even just what was the relationship with the person who died. Sometimes the person who died wasn't a very nice person. They may have caused quite a few wounds to that family member during the lifetime. So if there is room or space for some forgiveness to be expressed or some words to be said, we would of course try to encourage that. But that's definitely something like we can't change that, but we can acknowledge it as people share about it.
That was beautifully said, Christine. As a healthcare provider, I often feel kind of helpless in these sorts of situations. Like a lot of factors can make for a complicated grief, like if the person who's dying is young, or if the person who's died suddenly, or also if the person who's dying, it's dragged out for months or years. Like there are so many reasons why someone might experience complicated grief,
Mhm.
and that can feel like a big burden sometimes for healthcare providers. But on the flip side of that, when we get feedback from family members after their loved ones have died and they come back on the unit, or they call and they want to share their experience, they remember things like what you just said, Christine, like someone noticing them, someone taking time to ask them how they are, someone bringing them to a private space. Like it doesn't have to be a big thing. And they often don't remember exact words or, exact
Mhm.
advice, but they will remember the feeling that you left with them. So
Mhm.
I think that's sort of what I remind myself, is that you do have a impact in people's grief,
Mhm.
but it's more about who you are and how you are in the room. It's not necessarily exactly what you say or exactly what you do.
100%. I agree with that so much. One phrase I think I've used before is maybe we can't change the outcome, but maybe we can change something about the story. People are going to tell a story about what happened. And so we have an opportunity to impact the story in a positive way.
That's really beautiful. I feel like we could end the episode there, but there's a bit more that we can talk about as well. And I think another really big part of end of life is people's cultural and spiritual beliefs around end of life. This can really influence how families experience end of life care and grief. And so we want to respect their traditions and preferences. So this is where, Christine, you get to shine and give us even more helpful advice as you've already given us in this episode. But what is the role of spiritual care in end of life, and kind of what can you guys provide to patients that when,
Mhm.
a nurse refers them to spiritual care, what are you guys going to do for them, I guess?
Well, part of the spiritual care role is to assess. So, to assess, are there any particular cultural or religious care needs around end of life, either around end of life or at the time of death or after the death? The chaplain would hopefully be able to create some space for conversation. Often it's not with the patient, it might be with a close family member or someone that we could identify that maybe is in a kind of a leadership role in that family. That would more likely be the person that we might speak with outside of the room to try to assess that or find that. So the context of building relationship with the family, even if it's just for a short time, is important. So if I have a sense that maybe this is going to be something that we would need to address at some point, I would try my best to even just like saying hello in the hallway, introducing myself, just trying to get a little bit of a relationship going with the people that I see maybe are key people in the family. And I would explain my role, and that I would say something like, it's very important to us to understand customs and spiritual practices that are important to you. And part of my role is to try to understand that. And then I help the nursing team to understand what they might need to help you with. And so then I would start to glean this information. Sometimes I create I call it an end of life protocol to share with the nursing team. And I have some general protocols for various religious cultural traditions that I can share, but I would try to make this personal to the family as much as possible. The family are the experts in their own traditions, so I would want them to guide us. And it's important to never assume something, gently ask about it. So even if we do have some information or experience about, say, another patient that was Buddhist, and we know something happened in this way with that patient, we shouldn't assume that it would be the same way with another family. So we need to gently ask. So this is an end of life cultural protocol for Chinese family tradition. So I thought this is kind of an interesting one. The patient was Chinese and non-religious, but the family ended up sharing some things about what they wanted to happen after the death. So, specifically, the wife asked that the patient's dentures would be put in and that he would be dressed in clothing that he had with him at the hospital. I don't know if this was the same case, but sometimes people even bring specific outfit of clothing that they want their loved one to be dressed in after death. And then a white sheet was placed over the body but not covering the face. Then the patient's wife, who is quite elderly, was able to come and pay respect to her husband before he was taken off the unit. I think that one was maybe even during COVID. So we had to manage because one person could only be in the room at a time. But that was something very important to her, that he would be shown respect. And there's some belief that you're sort of preparing the person for the next life by having them dressed in clothing and so on. So this is part of that tradition. And then another one that's probably familiar to some people is Islamic tradition. So again, this is a general protocol for Muslim patients based on a brochure from the Islamic Funeral Society. So if you're able to get a hold of that. That's a good resource to have on your unit for nurses. But again, nurses are encouraged to confirm with the family if there are any cultural traditions specific to that family. But generally, what would happen is towards the time of death, that some family members would read or chant or sing passages from the Quran, the Muslims' holy book, around the time of death. And so recognizing that as a sacred space. So when you come into the room, to do that quietly and recognize that there may be some rituals that are happening around the time of death. It's important for Muslims to be buried usually within 24 to 48 hours of their death. So if a death certificate's not already been prepared in advance, knowing that the death is coming, sometimes we do that, ask the physician to prepare that, then we would want to secure that pronouncement and death certificate as soon as possible so that the body could be discharged from the hospital. Nursing may remove needles, tubing, catheters, etc. from the body. And please close the eyes upon death by supplying a warm cloth. And please try to keep the mouth closed. So you may actually use something soft to bind the lower jaw closed if necessary. The limbs would be attempt to have them straighten, but not in a forceful manner. And then the body would be covered with a white sheet before the body's transferred. So those are some examples of something that I might put together to help the nursing staff. But if you don't have access to spiritual care and things are unfolding, again, gently ask and say, we want to be respectful of your traditions and we want to understand anything that you would want us nurses to do around the time of death or after the patient has died. What do you need help with? Because we want to honor your tradition as much as we can.
That's some great advice, Christine. There is an e-booklet from AHS that outlines some different religious and traditions, and so we can have that linked down below as well if you're even just interested in different religious and cultural practices at end of life. After death, it's also important to consider that while the patient may have passed away and there is an ending there, that there is a transition to a new journey for the family as they navigate life after the loss of their loved one. And so I think we touched on this a little bit earlier, but making sure we're facilitating bereavement support. So offering that support and guidance to families as they navigate the grieving process after the patient's death. This may include connecting them with bereavement counselors or support groups. There may be some great online resources through the Canadian Virtual Hospice at mygrief.ca where individuals can learn and move through their own grief experience at their own pace in the comfort of their own homes. And I guess that is the end of our conversation in case anyone has anything else to add.
I'd just like to say thank you for inviting me. That was very interesting for me to join your chat. So thank you for inviting me.
And thank you for joining us on this episode. As a reminder, we would love for you to fill out our feedback form linked in the description below. You can feel free to comment something. We've given you a few things you could comment on in this episode, or maybe something that you learned in this episode that you'll carry forward in your practice. We would love to hear from you. But for now, take care and we'll see you next time.
Bye.
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 Bye.